Just let more people join. Alrighty, let's begin. Good evening and welcome. My name is Namita and I am the GP Liaison Officer at Ramsay Clinic, Macarthur in Wentworthville. I am beyond delighted to introduce this much anticipated GP education webinar, Puberty Blues, Adolescent Mental Health Presentations. This special interest series presentation has been put together by Dr. Veena Raghupathy, who is a well-renowned psychiatrist based at Ramsay Clinic, Wentworthville. Should you have any questions throughout the presentation, please pop it in the Q&A box below, and we will endeavour to answer as many of them as possible at the end of the presentation. Please be advised that this session is recorded and will be available to review afterwards. Aside from this, without further ado, I will now hand over to Dr. Raghupathy. Thank you.
Thank you, Namita, for such wonderful introduction. It's a bit different to do this type of presentations without having to look at the audience, having to look at the slides. So if I'm speaking too fast, do raise your hand saying that slow down. And I'm also happy to take on any questions, as Namita said. So I'm delighted to present to the primary care health sector for today. So I'm also waiting for all those questions, to hear those questions. So my topic is puberty blues. What I've tried to cover is the normal adolescence and also some of the mental illness and disorders that we get to see during teenage years and how they can present both in a primary care setting and secondary or tertiary levels. So I would like to start my presentation with the acknowledgement of the country. I acknowledge the traditional owners of this country and on the land on which we are meeting today. And I pay my respect to the elders of the past, present, and emerging. And also I would like to acknowledge the lived experiences of people with mental illness and suicide. And this presentation is all about helping people with lived experiences and also our patients who are our motivators. Okay, so introduction. Why this topic aimed at general practice is, in my experience, we often talk about specialist care, specialist mental health care. But what I have seen both from the private practice sector and as well as being and also a public child psychiatrist, I see most of the patients present to GP. And often you as primary care practitioners, you hold most of the case management and coordinate the case management. And there's only 1/3 of the patients with mental illness have been managed by specialist services and 2/3 in primary care settings. I think therefore it's important that we support you and in providing this care. And advantages of GP setting against any specialist mental health care setting is you also have intergenerational perspective. I often come across families who come along, oh, I've been seeing this GP and now my child sees the GP. So you kind of provide that overview of the family functions as well. And you have the regular opportunities to observe child-parent relationships. And GP practice is less stigmatizing. And the contact levels can also present opportunities for interventions too. So if we look at the normal adolescence, it's a roller coaster period because they're on the 12th birthday, they are still a child. And on 13th birthday, they are on their transition to becoming an adult. So they go through roller coaster changes from the bodily changes, hormonal, cognitive, neurobiological, as well as psychosocial. As we know, the hormonal changes actually makes them more impulsive and exacerbate their emotion dysregulation. And psychosocial changes is where they're developing their identity, their individuation from family. They try to walk away a bit more from family into the community, trying to form their social connections. When there is disconnect or when there's chaos in the form of cyberbullying, friendship difficulties, they can feel quite dejected and vacuumed. That can also present as mental health problems. And when we adolescent psychiatry, there is this special interest these days in forming that as a separate stream of psychiatry. Why is this so important? We know many mental health disorders which are more established in adulthood. They kind of run their roots in childhood. And most of the childhood disorders like autism, intellectual disability, ADHD, they tend to have sequelae persist in adult life. So the burden of psychiatric disorders often begins quite early in development. And the process of dysfunctional adaptations can be quite sometimes complex. So it is important for early recognition and treatment. And in pediatric psychiatric disorders, if you see, they often go under radar. They're not that obvious. They rarely present as pure psychological problem like I'm feeling depressed, I'm feeling sad. They're often present in the context of I'm having problems with concentration. I'm not able to, I'm not having enough energy levels. I'm not able to sleep. There's so many other somatic symptoms they often present with and often get extensive investigations. And they're also more common among frequent practice attenders too. The rates of psychiatric disorders in attendees in primary care settings, they increase as the years go by from 1 to 4, and then it evolves into 4 to 10 in the late teen years. The common presentations can be school refusal, behavioral problems, substance use, emotional difficulties, suicidal thoughts, social anxiety, or eating problems. Mood disorders. I'm just trying to move this so that I can read my slide as well. I will share this presentation after we complete our session today. So with the mood disorders, the prevalence is, as we know, a 12-month prevalence rate for major depression is around 6% when compared to bipolar disorder, 1%. Lifetime risk, again, it's quite higher for depression, around 15%, and with bipolar spectrum disorder is 2.5%. In primary care, in GP settings, 1 in 10 patients often present with depressive symptoms. And usually the onset of first episode of depression is in adolescent, and sometimes it can go up to mid-40s. 40% of patients with depressive disorder experience their first episode before the age of 20, and often they are more common in females compared to male. And if you look at bipolar disorder, the mean age of onset is in late teens, and often the diagnosis by late 20s. Usually, even people with bipolar disorders, they often tend to present with depressive episodes in their adolescent years, rather than hypomania or mania, unless they have a very strong family history or underlying brain disorders. And they have a much higher suicide risk compared to people with unipolar depression. And the gender ratio remains equal. This has been adapted from new psychiatric college guidelines, which was published in 2020. If you see previously the DSM-5 criteria, it's all about low mood, at least for 2 weeks period, and accompanied by 2 to 5 symptoms of the list. But the new college guidelines have tried to divide the symptoms into 3 different categories: emotion, which is marked as red, and activity, which is more of the psychomotor activities in green, and the cognition as red. The upper half is more bipolar disorders, and the lower half is depression. So for anyone, say for a patient to be diagnosed with depression, they should be present in for at least 2 weeks with depressed mood, accompanied by anhedonia, which is a very prominent feeling of losing interest in their activities which they previously enjoyed, as well as feelings of guilt or worthlessness, loss of energy, either they're sleeping too much or sleeping less. There's usually a difference of 1 to 2 hours of sleep to their regular sleep pattern. And the weight and appetite can be either increased or reduced. There's psychomotor agitation, retardation, indecisiveness, concentration problem, and suicidal thoughts. Sometimes they can be intrusive with plants. On the other hand, with hypomania and mania, the irritable mood or expansive mood of duration 4 days to a week, associated or accompanied by flight of ideas or racing thoughts, risk-taking behavior, increased energy and activity, very less need for sleep, goal-directed activity increased, psychomotor agitation and pressured speech, distractibility, and inflated self-esteem. If you look about the variations in children and adolescents with regards to depression, the endogenous depression is very uncommon in prepubertal children. Unlike its distribution in adults, the incidence is quite equal in male and female, and the incidence increases once they hit the teenage years, like mid-adolescence. The predominant symptom of childhood depression may be irritability rather than depressed mood. Often parents come to you saying that, oh, they seems to have anger problem all of a sudden. They not seems to be the same person. They're disengaged. They're not interested in the family, but they seems to be very happy when they're playing with their friends. So that can be still depression because they present with irritable mood, with more of insidious onset, with still periods of normal reactivity when they are with their close friends group. Melancholic features like loss of appetite, loss of sleep, no energy levels, absolute indecisiveness, they tend to be a bit rare in adolescents. If they tend to happen like in quite early in adolescence or mid-adolescence, often look for an organic cause. And hallucinations, often young people present with voices in their head, which is more of a traumatic experience rather than psychosis. Or it's part of their personality vulnerabilities if it is happening in isolation rather than with psychotic symptoms. Finally, death by suicide is very uncommon in prepubertal children, but many children with harbor suicidal thoughts. But in observation post-pandemic, the suicide rates in adolescents have been increasing. And with bipolar disorder, the early onset bipolar disorder in younger adolescents can happen if there's a very strong family history, and quite rare in children because it's a disorder of frontal brain. And as the brain matures in late teen years, the disorder becomes more obvious. The unofficial term of pediatric bipolar is often used to describe the episodic, because you get to see in your practice often children who has had long-standing emotional problem when they hit puberty, or children, those with ADHD, with emotional difficulties, they hit puberty, they tend to become more irritable. And they're not sleepy, they're very impulsive, they have got more explosive temper. Often family comes saying that, oh, they must be bipolar. He's happy in one moment, he's cranky the other moment. They're too impulsive, they're all over the place. This type of non-episodic persistent irritability can come under disruptive mood dysregulation, which has many symptoms that overlap with ADHD and bipolar, but as for this long-standing, non-episodic picture. If you look at DMDD, like disruptive mood dysregulation, it is more like a climate, which is there always. But bipolar disorder is more like weather. It comes and goes. It's very episodic, if that made sense. Why a person develop mood disorder? It's genetic, it's multifactorial, it's also epigenetics, gene and environmental influences, their experiences of early childhood, experiences of abuse, neglect, loss, domestic weakness in domestic violence, which often present as chronic disorders in adulthood as chronic illness, life-threatening illness, financial difficulties, relationship breakup, separations. So it's polygenetic. We cannot separate one gene, but at the same time, many medical disorders can have a component of mood, And especially if children with asthma and when they go on steroid medications, they can present with steroid-induced mood disorder. So it's important to monitor the side effects of the medications what we give, and also at the same time screen for depression if there are concerns raised by families. When we look into the assessment, as I mentioned about all the symptom list, yes, we've got to look into them and for how long they've been having those symptoms. And also look into the family history. Anyone else in the family has got mood disorder? What else is happening in the family? And the developmental history, more paying attention to bullying, relationship, peers, gaming, trauma, and also the pattern of illness. Have they had any periods of break from feeling depressed? Or have there been any recent precipitants like change in family circumstance or bullying, relationship breakdown, or any new onset illness? And what have they been trialed on before? Have they seen any psychologist or any support? So categorizing, which would help you with your formulation, is diagnosing with what type of mood disorder they have. Are they brought any other comorbid symptoms like anxiety, substance use, personality factors, any medical problems that they may be having, and the treatment. The level of care for mood disorders, this is often important because usually for mild depressive symptoms, which can occur in face of stress, shift workers, especially when they've got sleep deprivation, because the moment I try to cover sleep disorders, I hope time permits for that. Sleep disorders, because if there's studies that have demonstrated if one person has not, somebody is having sleep problem, say for a period of 3 years, their risk of developing anxiety and depression increases by 10 to 20 times. And if that persists for 5 years, their risk of developing chronic illness like diabetes, hypertension increases, because the more lack of sleep, it affects your BDNF, brain-derived neurotrophic factor, and that kind of kills all your neural network. And that's what causes more of the symptoms to come on surface. So coming back to the depressive symptoms in stress and sleep depression, that needs to be treated through self-care and stress management. If there's mild to moderate depression, follow the stepped care approach. Again, lifestyle changes and psychosocial interventions before we can look into the medications. For more moderate, especially when the suicidal thoughts are coming on the surface, and the young person is not getting any better despite the psychosocial interventions, they have very limited engagement in psychosocial interventions, that's where we will look at medications and specialist services. If there's risk is quite heightened with severe depression, with suicidal ideation, or agitated melancholia, they are developing hallucinations and delusions in the face of mood disorder, that's when you would look at more inpatient care, either voluntary or involuntary. So just conceptualizing what I have just spoken about, it's always any treatment for mood disorder or mental health problems, they run in 3 streams. One is the lifestyle, psychosocial, pharmacological, and as the severity increases, we would again look into other neurostimulatory treatment like ECT or TMS. These are some of the online clinic and supporting information for clinicians, which you can share with your patients, because sometimes some young people are very reluctant to talk about their emotions with psychologists, or they may not have time to actually see a psychologist on a regular basis, especially for mild to moderate. You could use one of these online platforms to help them with strategies in managing their stress and emotions. And just a slide on management of major depression. As I mentioned before, it starts with the lifestyle changes of sleep hygiene, exercise, diet, and also looking into their substance use, which includes alcohol, vaping, smoking, and looking into their broader environmental to see what else is going in this person's life that's making them more stressed. It may be the increased workload at school, or is a family situation is getting difficult. So as a first line, linking them up with psychological interventions under better scheme. And as I said, if for moderate to severe, you can always look into medications. Most of the medications have demonstrated efficacy over placebo. It's more of the choice of medication depends upon the side effect profile, which is here. I would like to often match antidepressant depending upon what else is the patient is presenting with. Like if they have more anxiety, you would look at starting them on SSRI or SNRI. If there is cognitive difficulties, then you go with moduolactin, duloxetine. Sleep disturbance like agomelatine, mirtazapine. Pain, again, duloxetine, tricyclics. Tricyclics are often tend to reserve as third line if the patient has not responded to SSRI. Most of the studies in children and adolescents have got evidence for SSRIs, mainly fluoxetine, followed by sertraline. Other SSRIs have not been that well studied in children, but the efficacy kind of remains similar in adult population. Again, the choice of medication depends upon the side effect profile. Similarly, the management of mania, in addition to the lifestyle and psychosocial support, you'd look at either a mood stabilizer or antipsychotic medications. Usually, these are often prescribed by specialist service. So in GP settings, is more around maintenance and also monitoring for side effects and monitoring for metabolic syndrome. And escalation when when the patient is not coping well. Just been mindful of the time. With the personality disorders in adolescents, there's always this debate whether we should label whether we should diagnose our young people with personality disorder or not. The studies have shown the temperament and the personality vulnerabilities gets quite established in their mid-teenage years, teen years. And it's important to be aware of temperament traits because they often contribute to their presentation. And it's these personality traits can be it can be improved by linking them up with long-term psychosocial interventions, more psychotherapies like DBT, which looks at emotional regulation and distress tolerance. I think there is a saying that says if somebody gains mastery over emotions, self-regulation, most of the mental illness or mental health issues often get resolved. So though it is DSM-5, DSM-4, it's still the same DSM-5. There are 3 clusters of personality disorders. Often what we get to see in adolescent years is the cluster traits. Usually each cluster has got their own traits. They cluster A, where it's paranoid, schizotypal. They're more of avoidant, rigid, and they have a bit of reality testing issues and magical thinking. Cluster B are more dramatic. They have antisocial attitudes. Emotion dysregulation is very prominent, as you say in borderline personality, histrionic, narcissistic, and antisocial. Cluster C are more anxious. People are often preoccupied and they are avoidant. They are avoidant, dependent, and obsessive-compulsive personality disorders. If you look into anxiety disorders, the presentation of anxiety disorders in childhood shares many similarities and differences in adults. Sometimes they can vary significantly depending upon the age of individual. So it's important to differentiate what are developmentally appropriate fears and what else is going on in the person's life. Like if they have medical conditions or they are using some illicit drugs that can also present with anxiety states. Again, like mood disorder, the etiology of anxiety disorders is multifactorial, genetic, environmental influences. And the recommendations is always lifestyle changes, CBT, If they're not responding, then we would look into psychopharmacology. And usually childhood anxiety disorders, they generally remit, but they often increase the risk of their emergence in adulthood. Just have to move this a bit so that I can see the slide. So what's the clinical relevance of if somebody is presenting with anxiety symptoms? They're more likely to present with chest pain or panic attacks, chest tightness, they have trouble breathing, or they have trouble concentrating, or they can come up with recurrent headache, recurrent abdominal pain, or muscle pains, or not being able to sleep. So it's important, again, as I said, to establish the course of illness, for how long they've been feeling, in the face of, is anything changed in this person's life, or the stress has been built up. If you see, many young people often tend to present with emotional difficulties as they transition from primary school to high school, because in primary school, it's more structured, it's less demanding compared to high school, where there is change of every class. And there is increased social demands, increased school demands, the assessment, project work. The load increases, and the concentration problems, sleep problems can come on board. That's more in the face of increased school workload rather than clinical anxiety disorders. But if they persist with that, they will be more prone to develop adjustment disorder with mixed mood or anxiety, and which eventually results in emerging anxiety disorder or clinical depression. And also it's important to look into the medical disorders or medications that have been used to see if that's presented with anxiety problems or anxiety states. For example, I've had patients who had very low iron, and that essentially that young person had iron deficiency anemia. So she would have palpitations, she would feel chest tightness, she's got fatigue, low energy levels, she feels quite lightheaded, and had feeling a bit nauseous in the mornings especially. So she was treated for with various anti-anxiety medications for a period of 6 to 12 months. But when she came to me, when we actually checked her irons, our iron level, our hemoglobin was at 9. And the iron was very, very low. And no wonder why she was presenting the way she was presenting. And she was not responding to any treatment, because the primary problem was not anxiety, it was actually iron deficiency. So it's important to look into the nutritional screen, and as well as in another case where this particular young person would use buffers on and off for sports-related asthma, and would experience panic, palpitations every time they used buffer, but they associated that they would have panic attacks. But it was more in the face of salbutamol, beta agonist, that was causing palpitations. Yes, as I said, many usually with anxiety disorders, suppression anxiety disorders, and usually tends to occur pre-puberty under 12, and generalized anxiety is increases as the age increases. Panic disorders are more in late teens. Social anxiety is, as I said, the school age, high school age. As soon as they're transitioning from primary to high school, many young people tend to present with social anxiety, which is often very common cause for school refusal. Again, with treatment, as I said, CBT is the gold standard treatment for anxiety. And the medications is when the symptoms are very severe, and that's actually limiting the young person's participation in psychotherapy. The range of medications was similar to what we use in depression, starting with SSRI. We then look into SNRI. Sometimes young person may also have trouble sleeping and may not be responding to melatonin. We would also look into using alpha-2 agonists like clonidine. If they have underlying ADD, we can also use guanfacine or Intuniv. This is OCD, and not including all the diagnostic criteria, because I'm pretty sure you all are familiar with the diagnostic criteria usually with the OCD. It's again, either the repeated intrusive thoughts or compulsions, at least they're lasting for more than 1 to 2 hours every day for lasting for more than 6 months, causing functional impairment. And they can be seen both, they can be associated with autism or without autism. Again, the primary mode of the treatment should be still psychological. If they're not responding, then we would look into SSRI. Autism, when OCD is related with autism, sometimes the psychological approaches by itself may not be sufficient. So we may have to know, in addition to SSRI, they may also require a small dose of antipsychotic medications in managing, especially what we call as a neurodevelopmental OCD. How do we differentiate that? It's more commonly seen in children. If you put up prepubertal children, often they have higher rates of autism, ADHD, or Tourette's. If you look into adolescent OCD or usually clinical OCD, often people complain of unpleasant, intrusive thoughts or images. The compulsions, they know it's irrational, but they just still have to do that because they're quite driven by fear. If they do not do it, then something bad may happen to them or their family. So they hold the personal responsibility in having to correct that. But if you look into neurodevelopmental OCD, they may not be coming with any of those fear. What they can present with is they just have to do it just to get it right. So they may not have all those intrusive thoughts or images driving their range of compulsions. It may be just the feeling that they just have to do it just to get it right. So that's where it borders a bit more on that dopaminergic pathway. So hence they require a small dose of antipsychotic medication in managing that. PTSD, post-traumatic stress disorder, as I said, the person should have experienced at least or witnessed a traumatic incident which must be kind of life-threatening or may have to instill that fear of being life-threatening, there's safety, and followed by a range of traumatic symptoms where there are recurrent flashbacks, recurrent nightmares, and also the person's outlook for future may have changed, the memory problems from, say, trust issues, and also the hyperarousal, that hypervigilance, dissociative states, panic attacks. So this all forms a cluster of post-traumatic stress disorder. When it happens within immediately, and the duration is less than a month, we can name it as acute stress disorder. After a month, it's post-traumatic stress disorder. If it goes beyond 3 months, then it becomes chronic PTSD. In children, especially in out-of-home care children, we often see they may have not just one incident, and multiple incidents of trauma, and we put them collectively as developmental trauma because in addition to PTSD symptoms, they can also come along with the attachment difficulties, how they relate to their primary caregivers, and which also then generalize to how they relate to the world in general. And sometimes if the trauma has occurred in their, what do you say, the pre-verbal age group, like under 2, the developmental trauma was quite significant, then they can present with more sensory memories. They may not be able to identify what the triggers are, but they can present with this range of symptoms ranging from functional neurological symptoms of passing out to acute behavioral disturbance, which sometimes you would hear from people or foster parents or caregivers coming, telling you that, oh, out of the blue, they just have this massive meltdown. It's happening from nowhere. They were all right. It could be one of the sensory memory that would have triggered in a subtle way, which is hard to pin it down. So in addition to sometimes if there's no traumatic memories, which they could not remember, either because of the repression, which is like a psychological phenomenon, you could look at distress tolerance based type of therapies. Again, it's a self-regulation is more important key. And you can also use medications to bring them to that safe space. We will not be able to erase the traumatic memories, but giving an opportunity to the young person so that their arousal is so not heightened that they're at least able to participate in therapy. At least they can pay attention to the strategies that has been put forward. And similar medications, and also to dampen the hyperarousal, you would look into clonidine, guanfacine, propranolol, and if they have more dissociative symptoms or like hallucinations, voices, visions, then you would look at a small dose of antipsychotic medication. Self-harm in adolescents, I'm pretty sure you would, this is a very, very common, and it's increasing, especially post-pandemic. And it can present to professionals as a symptom of major mental illness, or it can be also a part of cultural norm. There's a contagion effort with self-harm behaviors. If you look into the actual definition, it is an expression of personal distress, usually made in private by an individual who hurts himself or herself or themselves. The nature and meaning of self-harm may vary greatly from person to person. The reasons why a person would hurt themselves may be different on each occasion, and it should not be presumed to be the same. In my experience, treating many young people with self-harm behaviors, their motive is often different. So it's often important to explore, is it helping them? Is they using it as more as an emotional regulation tool? Or they're high achievers, they're perfectionistic, and they're not meeting their own expectations, and they use self-harm as a punitive option. They've just not been perfect, and they need to be punished. Or it could be a combination of those two. Or sometimes they use self-harm to distract the intrusive suicidal thoughts. So it's often important to explore why they self-harm. Often young people, they open up. If you say that you're curious to know, you're not trying to judge them, but you're just curious to know the motive behind it, why they do it, and how often they do it, and what's the consequence, how does the self-harm make them to feel. Usually self-injurious behavior, it can be a range of behaviors, what I have described there. There's also self-poisoning, which is overdosing on prescribed medication or over-the-counter medication. There are other risk-taking behaviors. This you get to see more also in given we are a very culturally diverse community, and in some cultures self-harm is not acceptable. So they can engage in other self-sabotaging behaviors, whether it should be substance use, risk-taking behavior, sexualized behaviors, binge eating. It could be any of those. And the motive is still under the same, causing harm to self. With self-harm, as I said, sometimes it can be also seen as a risk factor for adolescent suicidal behavior, especially when it is happening in presence of a psychiatric disorder, and there had been a previous history of suicide attempt. Like it's very secretive. The young person would say that, oh, I just tried 8 Panadol, but did not tell anyone. I felt a bit sick the next day, but nobody knows. It's often important to ask, have they tried any other means? Do they visualize themselves how they would want to end their life? It's not we are trying to put ideas in their head. It's more about they already, if they have thought through the process, there is planning. So that actually helps you to do the risk assessment and how you would manage. And sometimes they may say they would experience suicidal thoughts or self-harm thoughts only when they are using substances, alcohol, smoking, or any other, or cannabis, or when they're going through the withdrawal is when they get the urges. So those are the 3 factors which tends to heighten the suicidal risk, especially in young people with self-harm behavior. Again, the risk assessment is the proper description of the behavior, the motive behind it, previous suicidal behaviors, and also screen for any major mental illness like depression, anxiety disorders, psychosis, or PTSD. PTSD is often a silent trigger for self-harm. And because there's always, especially when there is sexual assault trauma, there's a lot of shame and guilt associated and distrust associated with self. and that is often a very strong driver for self-harm behaviors and as well as eating disorder. Family and environmental factors. How does the family respond to self-harm behaviors, especially when there is not much of emotional responsiveness from the primary caregivers? If the self-harm is the only way, when they get to see emotional reactivity from parents, that may also be a reinforcer. Every time they feel disconnect with the family, they may want to do self-harm. So it's important to see the nature of the family relationship, and to look into what else is happening in this person's life. And as I said before, the social stress from the education or the school network can also be a massive driver for self-harm behaviors. Because if you look into the psychological milestone and how we have developmental milestone, when the child learns to sit, walk, or crawl and talk. Similarly, psychological milestones, every 5 years we do have a psychological milestone you need to attend. And if not, then there's a stuckness. The adolescence milestone is the identity formation, and a part of that, major part of that, is the forming connections, the quality of the social connectedness, how they are being linked in within the herd. It's more like the survival. If they're well linked within their herd, they would feel more secure. If they feel disconnect, they kind of carry this vacuum, which often seen as personality vulnerabilities, and they tend to self-harm, especially whenever their friend is not replying to the text message, or they're not getting what they want. Anytime they experience any disconnect, they're more likely to self-harm. And the previous experience of treatment and what's their motivation to change, and what support is available for them to help through their journey. Stepwise approach of managing self-harm. Again, the risk assessment is important, and the specific treatment of the underlying mental health disorder. If you feel the patient is at low risk, they tend to do it whenever they are stressed. It's more of a stress management, and you could manage in the primary setting. But if they happen in recurrent, it's often put to do a referral to camps or step down care like HES team in managing young people with repeated self-harm behaviors. If there's no response, then you would refer them to more specialist mental health services. Eating disorders in children, again, it may be a separate talk by itself as well. So what I've tried to cover is, it's it's important to ask those questions, especially when there is weight loss and the family is concerned about weight loss of the young person or weight gain, as we see in binge eating disorder. Or it's more, eating disorders often develop very quietly, but it's most common, third most common chronic illness of adolescents, and the mortality rate can be up to 18 times greater than those who are not affected. It's very common in young people between late teens, 15 to 18, 19. It's also the time when there's a lot of bodily changes, and again, the trauma history can trigger eating disorder in adolescents too. The DSM-5, I've tried to put disordered eating into 5 major categories, as anorexia nervosa, with serious illness, which is associated with intense fear of gaining weight, associated with distorted body image and denial of illness severity, and bulimia nervosa, where there's recurrent episodes of binging and purging behavior. So they can present with normal BMI. Binge eating disorders, there's repeated episodes of binge eating with or without purging. And it may be hard to say who has binge eating disorder, who do not, because they can still present with normal weight or overweight or obese. And in younger children, especially those with neurodevelopmental disorders, they can present with more afferent, where it is the feeding problem are not driven by body image, it's more secondary to sensory difficulties, or getting through adequate nutrition to the young person may be different. And there are other non-specified eating disorders. So when there is an eating problem, it's important to establish what's the nature and for how long the person is having these problems and what else is going on. Are there any other comorbid mental illness or any other physical illness? Is there any new change or trigger that has brought on? How severe is the problem? Is it causing any medical instability? Is the person is having any other risk-taking behaviors, including self-harm or suicidal behaviors? What else what are the other services that are the young person is linked in with? And that actually helps you in formulating a treatment plan for the young person. I've tried to include a slide on hospital admission for criteria for both medical and psychological, especially when there's bradycardia or tachycardia, and there is cardiac arrhythmias with prolonged QT, postural tachycardia with a variation of 20 beats, and blood pressure, hypotension, hypothermia, low potassium, basal less than 3, or BMI under 14, there's rapid weight loss or acute dehydration, and the community supports are failing, or there's mental health risk, mental health risk of increased suicidality. All these are, and then there's other comorbid conditions like depression, diabetes or pregnancy can also be criteria for hospital admission. I've included some of the statewide programs that may be helpful to contact if you're in doubt. There's also a New South Wales eating disorder toolkit that would help you in managing young people with eating disorder. Sleep disorders, which is very commonly seen in many young people. They often come like parents' reports. It does not sleep till late night. That can be a part of normal adolescence. But as I said before, it can also be, the chronic sleep disturbance can also increase the risk of psychiatric disturbance. And it can be also driven by underlying gaming or internet addiction, especially post-pandemic. To tolerate people, the whole family living under one roof, sometimes they have brought into all this screen addiction, and that has enabled that has kind of evolved into a proper gaming or screen or internet addiction these days. That is also one of the common cause for school refusal and school avoidance and massive functional decline in many young people. Especially, I've seen a couple of them where they've just spent all the wakeful time just playing the games. So the factors to consider, it's important what they're doing, what's the sleep routine, what's the nature of the sleep problem? Is it more like a delayed onset, or it's a low quality sleep, or they have a very busy mind, have they got underlying anxiety disorder? Are they using any caffeinated drink, or they vaping at nighttime that's interfering with their sleep? So sleep hygiene is very important. Self-help strategies to manage screen time, stress is important. You can consider melatonin when required. When there is underlying mental health disorders like anxiety, you can also consider clonidine. And in people with trauma, you can also consider small doses of antipsychotic medication. Autism. I've just added one slide here on autism. There were a bit more pamphlets. I would not expect GP by themselves managing the care of a young person with autism. And it's not a disrespect. I think the complexity increases as they step into the adolescence with the puberty, or with hormonal changes and the transitions. It's always done, the care is always done well if it's coordinated with pediatrician, child psychiatrist. There are not many community mental health services who would accept children with autism or intellectual disability. So hence the supports are very limited. So that's where I try to include a slide to see You can look into some of the medicational options, especially if there's underlying mood and anxiety disorders. You would still treat them like any neurotypical child or young person, but you've got to just be mindful of behavioral activation in people with neurodevelopmental disorders. And how would they present? You can just imagine ADHD 10 times more. So they just can't sit still, they're super active, not able to sleep. Emotion dysregulation is hit the sky roof, and it's as it the roof, and they can they can involve in a range of risk-taking behaviors, and that's often in the face of starting the antidepressant, especially SSRI. So that's where it's often good to start low and go slow, especially in children with neurodevelopmental disorders, to avoid behavioral activation. Schizophrenia in children, adolescents, is one of the most devastating psychiatric disorder. Although the onset is quite rare before the age of 10, the incidence has been of schizophrenia is actually steadily increasing through the adolescence to reach its peak in early adult life. For some reason, since post-pandemic, the onset of psychosis is getting quite younger. We are getting to see more younger children, like between 12 to 14, presenting with psychotic symptoms these days. So the clinical severity, impact on development, the prognosis of childhood onset of schizophrenia is what reinforces the need for early detection, prompt diagnosis, and effective treatment. Before a young person develops psychosis, often they can have this prodromal phase, where it's kind of, in one sentence, it kind of, it's like a destruction of their personality. So there is a gradual but marked decline in social and academic function. There's deterioration in self-care. It's very insidious. It was like they were doing so well in primary school, start of high school, they were kind of okay, but then they slowly lost interest. They slowly lost interest in doing school activities and talking to people, going out. They became more and more withdrawn into their own world, not engaging with school, not engaging with family, and also being quite odd behaviors. There's a bit of disorganized speech, disorganized behavior. Sometimes when they're quite stressed, they can present with positive symptoms, the glimpses of positive symptoms like hallucinations or extreme paranoia, but they can snap out of it once they've had good sleep. This can happen in prodromal phase when you doubt somebody is of ultra risk mental state. You can always refer them to early psychosis team under ultra risk mental state. They do not have to have a psychotic disorder, a full-blown psychotic disorder, but you suspect, it's important to refer them to early psychosis team. That brings to the end of my presentation. Oops, how are we going with the time? 2 minutes early.
Perfect, Dr. Raghupathy. Do you want to go to the next slide? We do have some questions coming through. If anyone has any questions, please pop them in the Q&A box below and we'll go through them shortly. Thank you so much, Dr. Raghupathy. That was a fantastic presentation. I know I learned something new today. Before we go to the questions, I'd just like to mention that this event is a registered RAC-GP event, meaning that you are able to get 1.5 hours of CPD points through this. Please grab your phone, scan the QR code, or wait for my email after this session with a link to a SurveyMonkey survey through SurveyMonkey, and you'll be able to fill that form out, and Ramsey will log those hours for you. It's not a self-log event. It is a registered event, therefore we will log the hours for you. I will now ask the questions that have come through. So Dr. Parker has asked, initiating medication. I've been advised by more senior GPs to not initiate medication for depression and anxiety in children. However, I am seeing more and more teens with these disorders and feel more confident initiating when psychological options have been exhausted. Is there an age limit that a GP should not initiate medication under?
There is no set age limit as such. If you look into my patient population, the youngest one whom I've studied on medication was 4 years. So it's not that I have studied for, and I mean, but I'm not saying that we should all medicate. As I said, there's no age limit for medications. I would be driven by the severity of symptoms. If anxiety or depression is stopping them from engaging in psychological interventions, and it is causing massive functional impairment, they're not doing anything. They're not going to school. They're not participating in any team sports. They're not interested. Then it's important to intervene and try medication. Again, the medication would improve the cognition and the activity part, and also can reduce the intensity of the worries and help to lift up the mood. But they are more effective when they're used in conjunction with psychosocial interventions and lifestyle changes. They go all in hand in hand. But in children and adolescents, that's where it's important to exclude any reactive depression. Say if they are at a friendship fallout, or there's bullying, there's a massive stress that's that's they're facing. Antidepressants have very limited role to change them. So they may not be seen very effective. Rather, sometimes they can get more agitated rather than helping them.
Okay.
I hope that answers that question.
Yes, it does. Second question from Dr. Parker is school refusal in context of depression. I struggle with what to advise at times. I've tried some time off or reduced days with varying success. What is the best approach for school refusal and when attending school worsens symptoms?
Yeah. So yeah. Again, with the school refusal, is often associated with either school-related anxiety, or sometimes they can be also under performance anxiety for various reasons. Especially in girls, often they have ADD, undiagnosed ADD, which somehow they manage during primary school years, especially those with higher intelligence. They're not even more adaptive in managing that. But the moment they hit high school, they crash down, and the school refusal can be driven, say, in high achievers, perfectionists with performance anxiety, and those who are a bit more socially conscious can affect them through social anxiety. And children with neurodevelopmental disorders is a massive transition. There are too many changes, and also there's sensory overload. So you can see the different patient population can present with different, the same school avoidance due to various reasons. So it's important to tease that out. The psychosocial interventions would help with individual problems. Medications like, I would probably use a small dose of propranolol if they have got too heightened anxiety that they're not able to manage. If that's what is getting in their way to attend school. Because I can say I have done so many exams in my life. I've done so many courses in my life. But I must say, when I was back in India, when I was trying to do my first PG entrance exam, I actually experienced a panic state. That has been my lifelong experience to see like, oh my God, that was so bad. Though it lasted for a minute, it was quite bad. So I can actually see when patients say that they have panic attacks, they feel so anxious, they actually feel terribly helpless. And that's what makes them to, the moment they are not attending school, it's a massive relief. So that's a reinforcer. So we do not want that pattern. The more time off they have from school, it also adds to secondary anxiety. It's similar to, say, if we have been on holiday and come back to work, we have a amount of work that we need to attend to, and we become more psychosomatic, like, oh my God, my head is throbbing. I wish I was on holiday for more longer. Similarly, high school students, if they miss a term of school, when they have to return, they have more workload until unless school have exempted that workload. Sometimes working with school and having a plan saying that, okay, they're exempting the workload, but their presence is what is more important rather than performance, is what would help with the graduated return back to school. I often tell young people, it's like anxiety, school avoidance is more like like you're working on your muscle. The more you give in, the more stronger it becomes, then it's harder to treat that. So the best approach is going to school. You can use medications to get them to school, and you can work with school to come up with a plan that would support them and make their presence, even if there's a sensory overload, giving them safe space. It would be a spot in library or a spot in office, or they can have their lunch or recess in office or in the library. That would give them that, or noise cancellation headphones. There are various options that school can come up with.
No, I didn't know that. Wow, yeah, that's great advice. Next question is from Dr. Karala Singham. I read Edronax can be used in depression if fatigue is associated in adults. Is that the case with adolescents? I find fluoxetine is the most recommended in adolescents. So
as I
Edronax.
mentioned, yeah. So as I mentioned, with the antidepressants, there are only very few which are well studied in children and adolescents. One, it's hard to do the studies in young people because of the various ethical restrictions. And so that's where it's if you look up for the evidence, RCTs, there's very less studies available which can compare. Most of the antidepressants are often compared to placebo effect. So I would, as I said, I would go with the symptom control. And I often, when I tell my patients and their family, I explain, look, yes, we have working with the diagnosis of depression or anxiety, but what is more important is symptom control. Enriching the person's life and improving their quality of life is what matters. And often you can have buy-in from the patient and the family with that. If they have not responded for others, if that's what if you would like to try, you can always tell them there's very limited evidence. Sometimes you can get a phone call from a pharmacist saying that, oh, we do not use this in children anymore. We do not use it that often in children. So sometimes you have to work not only with patient and family, but also with the pharmacist.
Okay. That was the last question. Dr. Parker did say thank you for all that information. Dr. Raghupati, if no one has any further questions, we have finished early. We'll just give it another minute or two. If anyone has any questions, please pop in the Q&A box now, and we'll get through them. No, nothing is coming through. Dr. Raghupati, did you have any final pointers to add before we end tonight's session?
No, not really. Thank you for listening to me, and I hope this presentation was useful.
Yes, definitely. So after I end tonight's session, I will be sending up a follow-up email with a link to the survey via SurveyMonkey. As mentioned earlier, please fill that out if you wish to receive CPD points. I will be on leave for the next 2 weeks. I just wanted to pop that in there. I was wondering if I'd have time. Put another question.
Namita, any further comments regarding, is that you?
No, so this is Dr. Litchfield. Oh, perfect timing. Any further comments regarding OCD in neurotypical versus neurodivergent?
So, as I said, with the neurotypical, the OCD often comes along with a phobic fear that that if they have to do all the compulsions, because with the OCD, there's intrusive thought or image or a belief. It could be any of those, and that often drives the compulsions. Compulsions doesn't have to be always overt, like hand washing or checking or any of those. It can be also covert, counting. It can be also the way they chew the food, in which way they do it, or it can be the prayers that they have to say certain verses of Bible every time they get this intrusive thought, or sometimes they freeze. It can be a range of issues. So but the neurotypical children often, especially in the teenage years, they often have as I said, the intense fear that something bad would happen to them or their family, or the fear of getting infection, the fear of doing something wrong, especially if they're religious family, being sinful. It's very ego dystonic. It is like, it's really against their values, and they feel really fearful having to do something about it. Otherwise, they're going to be not accepted within by themselves or within their family.
Yeah.
But
sorry. Dr. Litchfield also asked, if you can build on that, is need to be right versus phobic. So when you're
yeah,
done,
that's what. So it's more phobic. It's more that fear is that a phobic phobia of something bad would happen, and also it's associated with personalized responsibility, personal responsibility, that they have to do something about it to neutralize it.
Yeah.
But in the process, it's a bit of like a rabbit hole situation. The more they give in, their compulsions, they get more and more time consuming, and eventually takes up the person's whole wakeful time, and also interferes with the sleep time. But in children, like prepubertal children, they may not even have, they may not be able to differentiate whether it is against or it's in line with their values, because they cannot differentiate that. But if you look in neurodivergent, as I said before, they're more like just getting it right. They need to do it because they need to feel right about it. If you look in toddlers, they're like, Mom, I have to do this. Like, no matter how many times you reason, no, you do not have to do that. But they feel like, no, I have to do it. They will not give you any reason. But it's more protracted form of those type of like just getting it right phenomenon. That's what is a neurodevelopmental one. Because if you look into the neurobiology of it, the neurotypical OCD is more a phenomenon of the orbitofrontal, the base of the frontal lobe. But neurodevelopmental one, it's not only the base of your frontal brain, but also the other parts of your frontal brain gets involved. So that's where it interferes with the executive functioning as well.
Yeah. He asked any contrasts. Dr. Litchfield also asked, last question, PTSD in children versus adults, any contrasts between the both?
Yes, in adults, they get, adults, they can sometimes, they can conceptualize it better. And they can present with more like a textbook signs of PTSD. Yeah, the voices are there, the flashbacks are there. Yeah, it really, I do not see a future, memory is very weird, or they can present with panic attacks. But in children, depending upon the developmental age where they are at, their ability to appreciate or conceptualize the old traumatic experience can vary. And they often come with more behavioral response as an externalizing behavior, or it can be an absolute shutdown. And it does not have to be like to them, it would be for something that has happened to their pet. I had a boy who would get into this massive violent outburst the moment he sees a dog, because his pet dog was attacked by another massive dog. So it was like, it started off with that, but then even that picture of a dog would bring on that response. If you look into the fear center, it's the same fear center which is responsible for both shutting down anxiety as well as violence.
Yeah, tough when they shut down. Dr. Litchfield said, thank you. Any other final questions, please pop it in the Q&A box. I have had a few questions regarding the link to the presentation. So once this session is over, it is recorded. We then upload it to our intranet, and then I can send you a secure link. Please respond to the email that I sent through at the end of the presentation, and I will send that through upon my return from leave once that's available. Give it another minute. Thank you so much again, Dr. Raghupathi. I even learned, I'm not even clinical, and I learned so much. So it was absolutely fantastic.
Thank you.
I don't think anything is coming through. We might end it early today, have an early mark today. Thank you everyone very much for joining. And again, Dr. Raghupathy for this wonderful presentation. If any questions do arise in the future, please feel free to email me and I'll endeavour to have them answered for you. Thank you again, Dr. Raghupathy, and good night, everyone.
Thank you.
Thank you.
Bye.
Bye.